Alright, so this is where we left off last time. We discussed a bunch of various musculoskeletal conditions in the last video, and now we're looking at bone conditions. Now, as we keep going through bone conditions, make sure that you're able to relate it to various endocrine difficulties that we looked at when we were doing endocrine. And throughout this segment of the chapter is a good time to go back to endocrine, revise some of those parathyroid things. Later on, when we go to reproductive, that's where the other stuff comes up, right? Because endocrine didn't talk about the sexual endocrine stuff. So there was no major conversation about estrogen, progesterone, LH, FSH, all of that. So those are two different segments that are going to come together to really have impact on bone. The first thing they talk about here are common pediatric fractures. So you have your green stick fracture and a torus or buckle fracture. They're not exactly the most significant thing, and once again, they're definitely more of a topic that can pop up on NBME than pop up on your step 1. A green stick fracture is very much like a tree stick fracture, so it's an incomplete fracture extending partway through the width of a bone. And you see this all the time if you're running through woods or you're driving through trees. You'll see some tree branches are just hanging, the branch cracked and it's just hanging there, it's cracked halfway due to a bending stress, right? And that's what it is here. You had some kind of bending stress that really just caused it to have this kind of fracture that you can see here and the one that they gave in the book, right? So there was bending in it and it caused it to kind of crack open. The bone fails on the side of the tension, all right? So the tension is on this side, the same side you have the crack on. Compression side is intact, so this is the side that bone is being compressed together and is bending in that way. Bone is bent like a green twig, right? So very, very clear understanding. So tension must be on this side. You're pushing the bone on this side. It's compressing in this little angle right here, and this is where you have your fracture going through the bone, all right? So that's pretty straightforward. Then the other one is the TRS stuff, right? And you have to remember tension remains solid. The tension side does not break, right? So your torus fracture is when you have axial force applied to immature bone. Now, if you don't know what axial force is, then it's a little difficult to understand what they're talking about. Let me see if I can find something. Yeah, I mean, it's more of a physics terminology to understand axial force, but it's, let me see, what they showing here. Yeah, no, it's difficult to really show. It's more of a force you can apply on someone and do it, but you could tell from all the arrows that are turning here that it's more of a force where there's some kind of turning happening as well. It's not just a pushing or a pulling force, but there's like a turn kind of thing happening there. Right, so that's what axial force is, and when you apply the axial force, you get something like this. So you can see in a torus fracture, there isn't an actual break in the bone, right? The bone didn't actually break. You can see here too, the torus fracture, it's just inflamed and really red, but there isn't actually like an actual break in the bone like you have here. This is an actual breaking. This side is becoming compressed over here. Alright, so that's generally all there is between the two. A green stick fracture or a torus fracture, those are the only two mentioned on in your first aid, so just worry about that and that should be good enough. This next tiny segment right here is actually a really important topic. It's pretty high yield. There's almost 100% guarantee it'll be on your step 1, which is achondroplasia. This is a failure of longitudinal bone growth, right? So achondro means without endochondral ossification. There is no endochondral ossification here. It's not working. And since that process is not working, you end up having short limbs. Membranous ossification is not affected, so you end up having a large head relative to your limbs. Constitutive activation of fibroblast growth factor, FGFR3, actually inhibits chondrocyte proliferation. More than 85% of mutations just occur sporadically. Otherwise, this has an autosomal dominant genetics, autosomal dominant inheritance with full penetrance. So if you have homozygous, if you get the dominant allele from both parents, homozygosity is actually lethal. You'll die. So if you have achondroplasia and you inherited it from a parent and you're alive, that means you must be carrying the recessive allele as well, right? Associated with increased paternal age, which is really interesting. Usually things are associated with an increasing maternal age. This one is associated with an increasing paternal age. Really important to catch that here. Most common cause of short-limbed dwarfism. It's actually the only short-lived dwarfism I really know about, right? Where the limbs are the only thing that are short, but the rest of the body, the head, the chest, it's perfectly fine. In the beginning, when we were just getting started with MSK, we were in the anatomy physiology section. Let me see if I can find that thing again. Right before getting to... Sorry, wait, actually it was an embryo, right? Oh, there is no embryo thing here, okay. I'm trying to remember where... I think it's the end of all of this stuff. After lower limb, blah, blah, blah. Yeah, right here. Okay, so right before pathology, okay. I have this image here that I kind of wanted to show you guys. So right here, we kind of discussed osteoblast, osteoclast, and we talked about osteoclast differentiation. This is all the stuff we did at the end of anatomy and physiology. And that video, we also talked a little bit about achondroplasia right here when we discussed bone formation, right? Endochondral ossification and stuff. And you have to remember what bones are actually going to develop correctly and what bones are not going to develop correctly, because you can easily get a question on achondroplasia. I've seen many questions on it on your NBMEs, and then it can definitely be on your step 1. So here we're looking at intramembranous versus endochondral ossification. And these are the things that are all intramembranous ossification, right? So the things that are purple. Everything else is going to require endochondral ossification, and that's everything that's blue. So in a patient, right, I wrote over here that the mandible forms mainly by intramembranous ossification around Meckel's cartilage and is often prominent in achondroplasia. As for the occipital bone, except for its upper portion, the rest of it forms by endochondral ossification. So the upper occipital bone will be fine. Endochondral ossification around the foramen magnum and may be dangerously stenosed in achondroplasia. Endochondral ossification is defective, so the only unaffected bones are the skull, except for the base. So that's what we're talking about, the occipital part. So the skull, the mandible, maxilla, and the clavicles. Right? And that's kind of what we're seeing here. The skull, the maxilla and mandible, and the clavicles. And that's it. Everything else is not going to be developing correctly in a patient with achondroplasia. So it's really significant to make sure you remember that stuff. The next half of this page talks about osteoporosis, which is really significant, right? Because osteoporosis and most of these bone disorders, we're going to see lab values later on. Most of these are directly related to PTH or menopause, and you really have to be able to go back and make that connection and really understand the calcium and the PTH relationship, as well as the estrogen relationship. We also talked about that a little bit last time. The estrogen relationship was discussed as well in that same segment over here. Not last time, but I think 2 videos ago, where they tell you about estrogen here, right? Estrogen inhibits apoptosis in bone-forming osteoblasts. So you're going to make osteoblasts live. That's good. And induces apoptosis in bone-resorbing osteoclasts. You're going to kill your osteoclasts. So what estrogen is essentially doing is it's making you make more bone, and it's stopping you from breaking bone. Causes closure of the epiphyseal plate during puberty, and if you have estrogen deficiency, either because of some kind of surgery or you're at menopause, you get more cycles of remodeling and bone resorption because you'll have more osteoclast activity. You're no longer going to be killing your osteoclasts. In addition, we talked about this thing called osteoprotegrin. Protegrin protects you. It's a rank ligand decoy receptor that binds rank ligand to prevent the rank to rank ligand interaction, which also decreases osteoclast activity. And another thing that estrogen does is estrogen upregulates the osteoprotegrin production from osteoblasts, right? Because remember, estrogen makes you have more alive osteoblasts. So you really need to remember that little connection of estrogen to bone, because that is also often tested. So now looking at osteoporosis, this is a very high yield topic, probably the most commonly tested bone issue. You're going to have trabecular, spongy, and cortical bone losing mass and interconnections despite normal bone mineralization and lab values. And that first sentence right here is just really significant in itself, right? So you're going to have normal bone mineralization and normal lab values. So your serum calcium and phosphate will be normal, right? Don't mess that up. That's going to be normal. Don't pick something with high calcium as if you're breaking your bone or something. But you end up losing bone mass. You lose bone interconnections. You end up getting very trabecular design where the interconnections are becoming lesser. So if you look here, they do a pretty decent job of visualizing it for you. So basically your normal bone, you can see, is really dense and there's only tiny dots in there and that's it. Now you have a lot of darkness in here, right? That's a lot of empty space without actual bone mass. And the weird thing that your intervertebral disc does, it has a central expansion. So if I zoom into that little section right here, so basically what's happening is, you see how the vertebral disc here is pretty much just flat? Here the center is big, the ends are really thin. In fact, this end over here is becoming so thin, right? It's becoming so thin that these two parts of the bone are about to start touching soon. And because of this, your intervertebral foramina over here is becoming smaller. Right? And that has a lot of stuff going through it as well. So you don't want that to happen. That's not going to be good. That's going to cause pain. Most commonly due to increased bone resorption related to decreased estrogen levels and old age, right? So it has nothing to do with PTH as far as you can see. Can be secondary to drugs like steroids, alcohol, anticonvulsants, anticoagulants, and even thyroid replacement therapy, or other medical conditions like hyperparathyroidism, multiple myeloma, and malabsorption syndromes. Now, of course, osteoporosis itself is not related to PTH, but PTH is related to osteoporosis. If you have a lot of PTH activity and you're breaking your bone to release more calcium, that will lead to osteoporosis, right? So keep that in mind. Just because one thing, things don't have to work both ways. Not everything has to work both ways. So osteoporosis is not due to PTH, but PTH can lead to osteoporosis if you have too much PTH secretion. Diagnosed by bone mineral density measurement by the DEXA, right, the dual energy X-ray absorptiometry, at the lumbar spine, or total hip and femoral neck, with a t-score of less than or equal to negative 2.5. Right, so the t-score should be less than or equal to negative 2.5 for you to be diagnosed as someone who has osteoporosis. Right? If your t-score is more than negative 2.5, such as negative 2, negative 1.5, then you're not exactly at osteoporosis yet, but you're getting there. All right? So really important to understand that DEXA score thing. You can get a silly NBME question on that as well. It can also be diagnosed with a fragility fracture, right? If you're getting fragility fractures, that's a huge giveaway that this patient has osteoporosis. Your bone must be looking like this. Right? So fragility fractures can occur from a fall, from a standing height, or minimal trauma, right? Fragility fracture is exactly what it sounds like. You're so fragile that you fractured yourself from something that really wouldn't cause a fracture in someone whose bone is okay. One-time screening is recommended in women over age 65 just to see how bad their osteoporosis might be. Almost all women of age 65 or above will have osteoporosis, mainly because of the menopause they've been in for the longest time, and then there's more chance of being in osteoporosis if you just didn't take good prophylactic care of yourself to not have a bad older age, right? So you can see prophylaxis is with regular weight-bearing exercise and adequate calcium and vitamin D intake throughout adulthood. Right, so you can get, I remember seeing a question on NBME that was exactly about this. They gave like all the answer choices, and the question was about like, what could you do to really prevent osteoporosis or something, or what would be the strongest indicator of how bad this woman's osteoporosis will be. And answer choices had everything. They had all the things as answer choices. But the correct answer was weight-bearing exercise. How much weight-bearing exercise she has done in her early life would really determine how bad her osteoporosis is going to be later on. Treatment is with bisphosphonates, teriparatide. This is a really important one. Teriparatide is pretty much related to PTH. SERMs, selective estrogen receptor modulators, right? We're going to see more of these when we get to reproductive. Rarely calcitonin, exactly, it's not a very effective thing. Denosumab, this is a monoclonal antibody against rank ligand, the bad guy. Rank ligand is the guy that's going to attach to rank and activate osteoclast, which will break bone. You don't want that to happen, all right? So these are all your different medications that you have to know about. At the top, they tell you about a vertebral compression fracture. Right, so we already talked about the fragility fracture, which is a fall from standing high or any kind of minimal trauma leading to a fracture at either the hip or the vertebra, anywhere. A vertebral compression fracture will present with acute back pain and loss of height or kyphosis. It also can present with fractures of the femoral neck or the distal radius, which I show you right here. Right, this image here is showing you what's known as a Cole's fracture. Right, this is your distal radius is just broken. This can happen because you were falling, you tried stopping the fall, right, and then you fracture your wrist. So it looks painful, and it definitely is. These are all the different kinds of things that happen to patients because they have osteoporosis, and it's most notably going to be a very elderly female. As you can see from the questions we have right here, right, this URL question and this URL question are both about a woman over, say, age 70. Right, they tell you it has to be someone over 65, but these are both 70 and 72. So let's take a look at these questions. First one right here is a 70-year-old white woman is brought to the emergency department due to acute right hip pain after a fall. Excuse me. Alright. She was walking in her house when she tripped on a floor rug and fell, landing on her hip. So that's pretty bad. For her age, that's really bad. She has been unable to bear weight on her right leg since the fall and had to call for emergency transport to the hospital. She has no significant medical history, nor does she smoke, drink, or do drugs. Family history is notable for a hip fracture in her mom. Blood pressure is 150, pulse is 112. She's in moderate pain, and her right leg appears to be shortened and externally rotated. So that really sucks. There is tenderness and swelling of the right hip. Radiographs reveal a right femoral neck fracture. What changes in bone structure is most likely responsible for her condition? And the answer was trabecular thinning with fewer interconnections, which is basically what they tell you right here, right? Lose bone mass and you lose interconnections, even though you have normal bone mineralization and lab values. She has osteoporosis and is presenting with a Cole's fracture, but she's seeing it in her femoral neck. Alright? This one down here, this is a 72-year-old Caucasian woman, comes to the emergency department after several hours of severe upper back pain. She developed the pain after experiencing a sudden bump while driving over a pothole. No history of trauma or back pain, long history of COPD with exacerbations requiring glucocorticoids, and she quit smoking 5 years ago. BMI is 18, so she's really, really skinny. Exam shows point tenderness over the T10 vertebra, and X-ray shows a T10 compression fracture. So she was just driving, and then she hit a pothole, and her car just went up and down really hard, and she got a compression fracture. That's pretty sensitive. It shouldn't really happen. It doesn't really happen to everyone. But her being 72 and being on glucocorticoids is really exacerbating her condition. The PTH and calcium chart is given from page 369. Which point corresponds to her? Alright, let me show you that chart real quick so you know which one I'm talking about. This is the same chart basically from endocrine where they tell you this one. So they gave this table, and this table is often given, right? This would be like A, B, C, D, E would be your answer choices, and you have to pick which one applies to her. So the correct answer for her case scenario was right in the middle, right? It would be the middle point, which means everything is normal because her calcium and phosphate would both be normal. She has osteoporosis as suggested by her fragility fracture due to minimal trauma and her ethnicity, sex, age, smoking history, and glucocorticoid use. She would not have high calcium, low phosphate, or any of that stuff because she doesn't have a PTH dysfunction. She's just got menopause, right? She's got osteoporosis, but her calcium and vitamin D will be just fine. Her PTH will be fine too. Right, so really important to understand that. They love trying to convince you into picking a case scenario where her calcium would be high because she has a high PTH level and you stripped all the calcium off the bone, but that's not what happened to her. That's not osteoporosis. That's actually hyperparathyroidism. Right? There's a very thin line between hyperparathyroidism and osteoporosis. They present very similarly, but their labs are completely different. The root cause between the two are completely different as well, or is completely different as well. This is the exact opposite of osteoporosis. So this is osteopetrosis. Petrosis because you're basically petrifying the person, right? Becoming rock. Failure of normal bone resorption due to defective osteoclast. Defective osteoclast leading to thickened, dense bone that are prone to fracture. So now what's happening is your osteoclast is not working. Before you had too much osteoclast activity because you don't have estrogen to stop it. Now you have no osteoclast activity, so you don't break your bone at all. So you have this really, really thick bone that just breaks. It's so thick that the density is so high it can fracture, right? So you're still getting fractures, but for a whole different reason. Here, the main issue are mutations. Mutations, usually in carbonic anhydrase 2, impair the ability of osteoclasts to generate an acidic environment necessary for bone resorption. Overgrowth of the cortical bone fills the marrow space, leading to pancytopenia. Extramedullary hematopoiesis occurs. Right, so now you're going to have blood being made anywhere else because you can't make it in your bones. You filled up your bone marrow. So we just did Hem-Onc earlier, right? That was a chapter we just did right now. So this is a question case scenario where the question can actually start with pancytopenia. Patient maybe came in because they're sick. Right? They might have signs of extramedullary hematopoiesis, and then somehow they connected to osteopetrosis, but in the very early stages. Can result in cranial nerve impingement and palsies due to narrowed foramina, and that's really painful too, because what happens there is in your brain, if your foramens where the nerves are supposed to come out of, if they start getting really, really small and you start squeezing the nerve, you start feeling weird things all over your body, depending on what nerve it is, and that's going to be really problematic. X-rays show diffuse symmetric sclerosis, so you see bone in bone or stone bone, hence the petrification, and you can see that here, right? There's bone in bone. A bone marrow transplant is potentially curative because osteoclasts are usually derived from monocytes. Really important to remember that. They can give you a really simple question about that topic, and they'll be like, oh, the doctor decided to do a bone marrow. What is the theory behind doing do a bone marrow transplant? What is the theory behind doing a bone marrow transplant? And you would have to know that is because bone marrow would have monocytes, and monocytes give you osteoclasts. And all this patient needed was functional carbonic anhydrase 2, functional osteoclast, to break the bone in bone and have normal bone density. This middle topic is one we discussed twice or three times already because we saw it throughout, even from the beginning, right? When we were in biochemistry and we looked at vitamin D, we talked about osteomalacia and rickets. So here, now, remember, even in osteopetrosis, calcium and phosphate will be normal levels. Keep that in mind. But here, now we're going to start seeing difficulties in calcium and phosphate levels. So here you have defective mineralization of osteoid or the cartilaginous growth plates, most commonly due to vitamin D deficiency. You have to keep in mind that without vitamin D, you cannot absorb calcium, right? So if you're taking a lot of calcium pills but you're low on vitamin D, that calcium is just coming out in your poop. So you just wasted a bunch of calcium right there. X-rays show osteopenia and looser zones or pseudo-fractures in osteomalacia, epiphyseal widening and metaphyseal cupping or fraying in the rickets. Rickets is the ones that occurs. Rickets is the disorder that occurs in infants, whereas the osteomalacia is more for adults. Children with rickets have pathologic bow legs, or also known as genovarum, so you can see how the legs are not straight. Bead-like costochondral junctions, so this is the rachitic rosary they call it, right? Bead-like costochondral junctions, and craniotabes, which is basically a soft skull. So the low vitamin D leads to you having low serum calcium because you can't absorb calcium without vitamin D. And if you have low calcium, your body will always ramp up PTH activity, which would strip calcium off the bone and decrease your phosphate levels, right? Because phosphate trashing hormone, you're going to be peeing out all your phosphate. There will also be hyperactivity of osteoblasts here. You're making more bone, or you're going to try to at least, leading to increased ALP levels, right? So ALP is always increased when you have more osteoblast activity. Because osteoblasts require an alkaline environment and are hyperactive in this disease, trying to build bones, you're going to have elevated ALP, right? Osteoblasts are going to try to make bone and fix the issue. It's a young infant. He can do that. It's just not going to work too well. Also keep in mind that the hypophosphatemia impairs matrix deposition in the osteoid of the Haversian canal and trabecular surfaces. So the new bone that they do make is weak. If you don't know what the Haversian canal is and what the trabecular surfaces are, these are just parts of the bone inside the bone, right? So actual bone anatomy right here. So if you don't have phosphate, you're not going to make good bone. You need the right amount of calcium and phosphate. Everything is only perfect at the correct levels, not if it's too much and not if it's too low. Keep in mind that you can also get a question about osteomalacia, or, well, mainly rickets. You can get a question about rickets that makes it look like this is a question also about child abuse, right? Infant abuse. You got to be really careful about what kind of fractures you're seeing, right? These pseudo fractures or looser zones due to osteopenia are not a sign of abuse. This is just rickets. Abuse will have the fontanelle thing, the hemorrhage in the reticular stuff in the eyes, right? Remember shaken baby syndrome? That's usually what's really supposed to be used to establish the fact that this baby has gone through abuse. Whereas here, you're just going to see bone that's not really that good. The last two things here, osteitis deformans and avascular necrosis of bone. And we talked about the avascular necrosis of the femur a little earlier just in the last video. Osteitis deformans is Paget disease, which is really high yield as well, right? Right up there with osteoporosis. These two guys are really significant. Paget disease of bone is a common localized disorder of bone remodeling caused by increased osteoclastic activity followed by increased osteoblastic activity that now forms poor quality bone. Right, so osteoporosis was due to no estrogen, so you have more osteoclast activity breaking bone, right? Osteopetrosis, your osteoclast cannot work at all, so you have too much bone because you're never breaking it. Here, you have a bad balance as well. You have osteoclasts that break a lot of bone, then you have osteoblasts that makes a lot of bone, but it's not going to be that good. Serum calcium, phosphorus, and PTH are normal. So always remember that. Osteoporosis, Paget disease of bone, serum levels, the labs, they're normal. The only thing that's elevated here is, again, ALP, because your osteoblast activity requires an alkaline environment. Mosaic pattern of woven and lamellar bone, osteocytes within lacunae, and chaotic juxtapositions. These are all just descriptions that can be answer choices. So you have to be ready for that, right? They can ask you, they can present a question stem where they're talking about a patient with osteitis deformans or Paget disease of bone, same thing. And then they'll be like, what would you expect to see, blah, blah, blah. And this is what you would expect to see. You would expect to see a mosaic pattern of woven and lamellar bone. And you would expect to see osteocytes that are within the lacunae in weird, chaotic juxtapositions. Long bone chalk stick fractures. Right, that's also really important to remember, a chalk stick fracture. So if you've never ridden on a board with a chalk stick, you should try it out. See, if you pressure the chalk stick in the wrong way, it breaks. And the way it breaks is exactly how your bone will be breaking. You also have increased blood flow from AV shunts, which can then cause high output heart failure. This is a topic that was on a recent NBME. And they don't explain here how you're getting more AV shunts, but it occurs. Remember that bone is very vascular. There's a lot of blood vessels running through bone as well. And if you're breaking and building bone, the building and breaking of bone doesn't exactly look at the small blood vessels. It just cuts it off. It cuts off the blood vessel, and it makes bone. But blood vessels have a tendency to reconnect with each other, right? Re-network. So you can have an artery or a capillary and a venial right next to each other, and maybe you were building bone and you cut them both off. Well, they might reconnect with each other. Now you just connected the wrong things, right? And what happens here now is, imagine that all your veins in your body, imagine I suddenly turn them all into arteries. Now the number of arteries you have doubled, and that leads to high output heart failure. Your heart now has to send out more blood to get to all of those arteries. That's not that easy. Right? So now Paget disease is systemic. If it's happening in multiple really, really big bones all over your body, you're going to end up getting symptoms of heart failure. There's also an increased risk of osteosarcoma, which totally makes sense, because if you're breaking something, and if you repeatedly keep, for example, one thing a doctor had told me once was, if you keep ripping your lip skin, the skin on your lips, there's a chance of getting lip cancer there, because every time you rip it, your body has to make a new one. So every time you injure something repeatedly, you make new ones again from scratch. There's a chance of that new stuff being made, not developing correctly, and you getting cancer. Chances are obviously very, very slim, but it can happen. And as this case scenario with Paget disease of bone, chances are actually pretty high, because the disease itself is actually a disease, right? Like the whole condition of what's happening is a disease. Paget disease is doing it, and that's going to lead to osteosarcoma. You're not just breaking and making bone for something physiological. You're breaking and making bone for something pathological. which will only give birth to more pathology. So how will patients present? Well, one common thing, I've seen this in UWorld, is that their head size can be increased because their skull got thicker. Right? Hearing loss is also common because their auditory foramen narrowed. Right? These are things they can come in for. And then here are the stages of Paget disease, and I'll show you some pictures about this. So you have a lytic phase because lysis, right? Your osteoclast activity is first. You have to break something to make something over it. Right? So you break first, then you have a mixed phase, then you have a sclerotic phase where you make something but it's not that good. Right? And then you lastly have a quiet phase, a quiescent phase where everything is quiet. There's minimal activity of breaking or making. And the number one treatment here, most commonly used, if you have a patient with Paget disease of bone, give them bisphosphonates. Over here, let me see, where did I put it? Oh, right here. This is an image showing you those phases. Right? So you have your osteolytic phase, which is mainly osteoclast activity. So you see you have really open space here, right? It's empty in there. A lot of osteoclasts just breaking bone. Then you have a mixed phase, you're making bone too, so that's that tan colored stuff, so you can see the middle is becoming more full. And then in the ending you have your osteosclerotic phase where you just make a lot of bone but it's weak and thick and it can fracture like a chopstick fracture. Here, this is an H&E slide showing the lamellar bone with prominent cement lines. And this is something that can be described in a question, right? If you're looking at a bone histology and you see cement lines, you see the lines that we're looking at here, that's not normal, right? Normal bone will never have these prominent cement lines. But these cement lines are happening here because you're breaking and making bone constantly, right? Every week you break bone and you make it, and you break bone and you make it, and you end up getting these cement lines that you're seeing here. Every time you see cement lines, if you get a histoimage like this at all, that's a sign of Paget disease of bone. What is this one? This is also the rest of these are cancer. Okay, so we'll see that. But that's the next topic: primary bone tumors. But I wanted to show you the Paget disease image. Now here I wrote something. I wrote the Paget. The word itself is supposed to be used as like a mnemonic. So you can see the P stands for picture frame bone. Right? You can even look at this here. This looks like a mirror. Right? It looks like a mirror. This could also be a round or circular picture frame where you would just put a picture inside. Right? So it's got this really thickened skull. That's why it's called the picture frame bone. The A stands for AV shunts, which leads to heart failure. The G is a grown skull, which makes your head size bigger. Right? Ear narrowing is the E. And the T is the triangle, which is the Codman triangle. We're gonna learn about the Codman triangle in the next video when I talk about osteosarcoma. Osteosarcoma, the way that cancer grows, you get something called the Codman triangle. You want to remember this triangle. So Paget is a mnemonic for things that are related to Paget disease of bone. Last thing here are all the things that can possibly cause avascular necrosis of bone. So infarction of bone and marrow, usually very painful. Most common site is the femoral head because it's a watershed zone. Right? Why is it a watershed zone? Is because due to insufficiency of medial circumflex femoral artery. That's the one you always pick. There's two. There's a medial circumflex artery and a lateral one. But the medial one is not that good. It doesn't get enough blood. It's not that powerful. It's not that useful. It's very insufficient to begin with. And the slightest thing can make it more insufficient, leading to avascular necrosis. Right? Lack of blood leading to necrosis. That's what that means. What are things that can cause this? So most notably, you can easily get a question on this due to sickle cell. Right? Sickle cell patients have sickling of blood cells, which get stuck in all these capillaries, and then these capillaries, they don't work anymore. So it's really easy to get something that gets stuck in the medial circumflex artery, and now you don't have any blood coming through there, leading to avascular necrosis. The other really common thing was lupus. That's another one where you get this. And then we talked about this last time. Lecq-Calvé-Perthes disease. This is literally just the same exact issue but idiopathic. You have a bad medial circumflex artery for no reason whatsoever. That's exactly what Lecq-Calvé-Perthes disease is. We talked about Gaucher disease when we were all the way in biochemistry near the end. So let's actually go back and take a look. It's always fun to go back to biochemistry. Always got to revisit metabolism, right? So if we look at our sphingolipidoses right here. So if you look at Gaucher, remember I told you guys to memorize this guy as Gaucher, right? So he's from that, not cartoon, from the children's TV show. The reason we look at him as Goucher is because in Goucher disease, what happens? First of all, always got to remember what lysosomal storage diseases have hepatosplenomegaly. So that's one thing Goucher disease has. That's unique. Pancytopenia, not unique. Sorry, important. It's important to know which ones have hepatosplenomegaly because a lot of them don't. Pancytopenia is pretty specific to Goucher because the others don't all have it, but this one does. Osteoporosis, avascular necrosis of the femur, the topics that we're talking about right now, and Goucher cells, which are just crumpled tissue paper. So you see he's holding that right there? Right? He actually lives in the trash can, and there's going to be crumpled paper all over him all the time. Right? And the reason the trash can was also really helpful is because he has bone crises. He can't really walk. He just rolls around. The trash can itself is his defense. He doesn't have a strong skeleton to actually stand up, so he lives in here and he rolls around to get places. You have to use that to remember that. So Goucher disease is another case scenario where you can have osteoporosis and avascular necrosis of the bone, both. Other than that, they tell you everything: corticosteroids, alcoholism, any major trauma, and of course there's another one we talked about last time, the slipped capitofemoral epiphysis, where this segment comes out of the acetabulum. Right, this thing comes out of the acetabulum, and you have to put it back in there and do surgery and drill it in. So that's really important to watch out for. At the bottom, I have a question related to this. So this one is a 24-year-old African-American woman comes to the office reporting of left hip and pelvic pain. She has a constant dull, achy pain at rest that is exacerbated by movement of the hip or weight bearing. Her medical history is significant for sickle cell disease, pneumococcal pneumonia, and acute chest syndrome. Acute chest syndrome being a thing related to sickle cell. Temperature, blood pressure, pulse, respiratory rate are just fine. Cardiopulmonary exam is also normal. Pedal pulsars are full, and there's normal capillary refill and sensation in the feet. So everything is generally okay. No redness or warmth is present over the hip joint, but she has decreased passive rotation, extension, and abduction at the hip. What is the most likely cause of her pain? Well, she's got sickle cell. The pain is in that area of her hip. It's going to be avascular necrosis because she doesn't have any other comorbidities that would make you think it's something else. Avascular necrosis. She has osteonecrosis of her femoral head due to thrombotic occlusion because of her sickle cell disease. Right? Something occluded her medial circumflex artery. Microscopic analysis of the wedge-shaped zone of affected bone is notable for dead bony trabeculae, empty lacunae, and fat necrosis. Right, so really important to know how that happens, what's happening here, and just understand it very well. And that's it for that. So now on the next page, they really just break down the lab values, and you can see here they're also reintroducing to you osteitis fibrosis cystica, which was the hyperparathyroidism stuff that also breaks bone. What we just learned about right now, though, everything is normal. You can see osteoporosis, osteopetrosis, and Paget disease of bone have normal labs. Everything is fine. The only thing is ALP can be elevated if you have actual osteoblast activity, and that's always going to be true. It's not part of the disease, it's part of the fact that you have osteoblasts working a little more than normal. Right? So you can see osteoporosis, everything is fine. You lost bone mass because you have low estrogen. You are unable to turn off your osteoclast. Osteopetrosis is a carbonic anhydrase 2 mutation where your osteoclasts don't work at all. So you're never breaking bone. So you get really dense bone that easily fractures. Paget disease of bone we just looked at, you're making bone right after breaking it, and it's not looking too good. It's got a mosaic structure because of the cement lines, and that's bad too. The rest of these are things we've already talked about, right? So the rest of this chart from osteitis fibrosis cystica down to hypervitaminosis D is stuff we looked at in either biochem nutrition when we talked about vitamin D, or when we looked at endocrine, when we talked about PTH itself, right? So those are already just revision. If you forgot any of it, look at it again on this table, go back to endocrine to revise it there, and then in the next video, we'll break into primary bone tumors and how to really memorize them so that you don't forget them, nor do you get confused between one bone tumor and the other.